And here we go. Welcome everybody to The Big Idea. I'm Dr. Jeffrey Hanna. Today we are talking about Chiari malformations. And this is following a question that somebody had asked me on my YouTube channel. Will you address the relationship of a Chiari malformation and the upper vertebrae? I had a posterior fossa decompression and laminectomy of C1, C2 done many years ago. I have chronic neck pain and headaches. I worry about the safety of manipulation. We live in Alaska, and I see a couple of NUCA providers listed. Would it be of benefit in your opinion? Thank you. So this is what we're going to jump into today, and we're going to break this down into a few pieces. Number one, what is a Chiari malformation? Number two, what are some of the risk factors associated with it? And number three, what are my thoughts and what are the different treatments that are involved when we are dealing with this particular kind of condition? Let's get into it. All right, firstly, what is a Chiari malformation? And in all honesty, if you're watching this video, you probably know what this is because you're looking for information about what do. You've been diagnosed with this, or you know somebody else who is. But nevertheless, let's cover some of the basics. A Chiari malformation is essentially where your brain is bulging outside of the base of your skull and starting to descend into the space where your spinal cord should normally be sitting. And we're going to use a few analogies here. One of the first ones that I like is, think of, if you would, a balloon with a piece of string attached to it. And the balloon's going to be your brain, the string is your spinal cord. And what I want you to imagine, and I'll grab a little model to kind of demonstrate this, is that the base of the skull here, the balloon should be sitting inside of that vault. But if you were to take that string and you were to start pulling it down this way, the base of that balloon is going to start to bulge into this little space right here. And that's only going to have a finite amount of room in it like this. And as you start to have narrowing in that space, it can start to affect circulation of blood flow, cerebral spinal fluid flow. It can start to actually change hydrostatic pressures. And as a consequence, you can start having different degrees of neurological imbalances. Another way that you can think of it is that you wear a size, let's say a size 10 shoe, okay? Could you get your foot into a size 9.5 or even into a 9? The reality is yeah, you probably could, but you're going to feel the pressure on all sides. In a nutshell, that's what a Chiari malformation is. But we're talking about the base of the brain. And there's a few structures that can be involved here. So one of the most common ones is the cerebellum. Cerebellum is involved with all kinds of things in your body. It is fine motor coordination to all parts of your body. It's involved with muscle tone, muscle tension. It's involved with balance. It's involved with equilibrium. It also is a major relay coordinator for all of the functions that go on higher up in your brain. In other words, if you affect cerebellum, you affect the way that you can think, the way that you can move, the way that you feel, your emote, like everything can get involved when that's the case. And in more severe instances, what you can also have is you can have irritation of what's known as the medulla. It's your brainstem where all of the vital life centers are that go to your thyroid, your heart, your lungs, your blood pressure, your digestion, blood flow to all parts of your body. In other words, there's a lot of systems that can be involved with this. And here we have an image of an MRI here. And let me just point out a few structures. So the person would be facing this way, and it's from the side essentially. So their brain and their spinal cord is this light gray that you see right here. The base of their skull is this black triangle you would see here, this black triangle you see here, and then the vertebra here would be the C1, here would be the C2, C3, and so forth down like that. Now, there are a lot of different measurements that you can use to identify a Chiari malformation. One of the easiest ones is where you simply draw a line. Where's my line function? There we go. You draw a line across the very base of that opening at the base of the skull where I had showed you from point to point, and you're looking to see, does part of that cerebellum descend below that line? Now, here's where you're going to start getting a few different opinions, whether you're chatting with a neurologist, whether you're chatting with a craniocervical specialist. from the standard guidelines, we say that, okay, the base of the cerebellum here, it should be sitting on an average about 3 millimeters above the base of the skull. However, a Chiari malformation is commonly not diagnosed until you see that part of the brain descend into that opening by about 5 millimeters. The thing about it is that you can still have a lot of neurological problems even if that is crowding in that space. Again, think of too much tightness in that area around the base of the brainstem. You're trying to fit your foot into a shoe that is a half or a full size too small for you. In other words, you can still have the exact same kinds of issues, even if that is only right at the margin. It's what's known as a Chiari zero malformation. And this is where you can start getting a lot of different opinions. Some people, radiologists would say, no, there's no Chiari malformation here. But that doesn't mean that clinically you still can't be having the same kinds of issues. A way that I commonly think of it is, okay, let's say that you are 20 pounds overweight. But let's say that the definition of obesity is 30 pounds overweight. Well, it doesn't change the fact you're still overweight. There are still going to be a few problems. But if you are waiting until you're like 30 pounds obese to meet that medical definition and that criteria, you're waiting for things just to get worse before you would actually do something about it, when the reality is like, okay, no, let's see what we can do before it actually progresses and gets worse. What we also know from the literature is that when you're looking at MRIs are done in a lying down position like this. And assuming that there's not a history of physical injury, whiplash, or anything like that, if you were to take an MRI in an upright position, the incidence of a Chiari malformation actually doubles. And in fact, if you've had a whiplash injury, it's going to nearly quadruple. In other words, if you see even a relatively low-lying tonsil, even if it doesn't meet that full criteria, odds are it's clinically significant when you are in an upright position. And what's one of the things that people with the Chiari malformation constantly describe? I feel better when I lie down. Now, they can be having a lot of different symptoms. So neck pain, that's going to be a common one. Headaches, migraines, balance issues, brain fog, chronic fatigue, fibromyalgia, but also a lot of other weird symptoms, sometimes what's known as a Craniocervical syndrome, where a lot of these different kinds of issues can get lost in the mix. And if we're trying to fit a person into a nice, neat box, we're not necessarily able to do that. What I also want to point out here is when we're dealing with a Chiari malformation, this is a physical condition. Physical or mechanical conditions need physical solutions. In other words, simply giving medication to mask a symptom, it can help mask the symptom, but it will not address what the true underlying issue is. So just want to give a little bit of clarity first, what a Chiari malformation actually is and what it looks like on an MRI, something like this. Now, what I want to hit on next is the procedure that this person actually had and that they were describing. They said that many years ago, when they were identified that they had this condition going on, they had what's known as a laminectomy. This is a surgical procedure where essentially what they did was they said, okay, we've got the base of the skull. So here's the opening right here. We've got the C1 vertebra. So this would be like the front. This would be the back. And then we've also got the back of the C2 vertebra, which is the pivot point for the head, like this. So what did they have done? They had a surgical procedure essentially to make that space wider. In other words, they opened it up. They took some of the bone away. They took some bone away off the base of the skull. They took bone away from the back of the C1 right here. And they also took bone away from the back of the C2. So you're wearing a shoe that is decidedly too small for you. And what was done was they cut a couple of little slices in the side of that shoe. The theory being that you can actually get that space to expand for your foot, so it's not going to be feeling quite as tight. Now, you can appreciate that in case of a very, very severe instance, you know what, this might be what's actually medically necessary. But in the same breath, there's going to be a consequence with that. And it's because all of the different muscles, the ligaments, the connective tissues that provide stability for that area, if you take some of that away because you can't cut the bone away without cutting through some of those other structures, you're sacrificing, or you're working to try to improve more space, but you're sacrificing the structures that provide stability for that in the first place. And that means that sometimes people, even when they have medical procedure, they're still going to be symptomatic. And what did this person say? I still have headaches. I still have neck pain. They didn't elaborate beyond that. My point being is that surgery is not always going to be the first, option if we actually want to do that. Unfortunately, there are a lot of conservative options that can be involved as well. And I'll get to those in just a wee little bit here. But first, I want to outline for you a few of the things that contribute toward a Chiari in the first place, because it will explain a little bit more about what would be some of the different treatment options that you would want to look at before you would pick surgery. And even if you have had surgery for something like this, what can still be done that's going to help stabilize that so that you're getting the best of both worlds. So let's start out with a few things here. First thing that I want to hit on is normal anatomy. First up, there is no such thing as normal anatomy. Why? All human beings, we are different on the outside and on the inside. So this is going to be our facial features. These are going to be the way that our joints come together, but also the orientations of the bones of the skull. So oftentimes people would say something to the effect of, oh, my mother had migraines and her mother had migraines, and so that's the reason I have migraines. They're genetic. Migraines in and of themselves, as an example, they're not genetic. But what we do inherit is we do inherit the bony features of our ancestors. And some people, bony features, they allow us a margin of error like this much. And other people, through no fault of their own, they inherit bone structures where they can only tolerate this amount of stress. Therefore, they are more likely to experience these similar kinds of problems, similar kind of symptoms. But again, just because you may have a certain gene, a certain bone structure, that doesn't mean that you necessarily need to suffer needlessly through the course of your life. So what are a few of the risk factors where if you know that you've got this, you need to make sure that you are all the more diligent so that you don't get these issues later in life? It's, for example, if you know you've got a family history of cancer, you know you have a family history of diabetes, you know you have a history of cardiovascular disease, guess what? You need to be more cautious in your lifestyle to make sure that you don't develop these things later on in life. So what are some of these as it relates to Chiari malformation? Well, one of them is what's known as a shallow posterior fossa. This is the shape itself of the back of your skull. What we have here is an MRI, and this is actually a relatively young person. Let me get my little yellow lines out here again. So in this person's particular case, the back of their skull is very steep, like this. For some people, it's going to be shaped more like that, where there's kind of a hollow that essentially protects where that cerebellum should be sitting. But if the back of that skull is steeper like that, guess what? It makes for a slipperier slope. It's more likely that you can start to have this kind of descent. And then if you have some of the other factors that I'm going to mention in a moment, it is more likely that you can start to become symptomatic for this. And again, this is not necessarily something that surgery by itself corrects. You can't change your bone structure or your genes, but you do have to make sure that all of the other factors are working as good as is humanly possible. So that's number one. The second one is what's called a basilar impression. What a basilar impression represents is a feature where you are looking at the base of the skull and the C2 vertebra in particular. So what I want to illustrate is if we were to draw a line, something like this, across the floor, essentially, of this person's skull where the upper part of their brain meets. The bone is going to come along like this, and it should have a certain length associated with it. Some people, the length of that bone, again, anatomically, genetically, is a little bit shorter. When it's shorter, the rest of the joints of the spine are going to start to ride upward. And what it means is it means that there is potentially not as much functional space in this particular area. As a consequence, it's possible then that that C2 vertebra starts to project somewhat upward. That's what a basilar invagination is. And it can point or put mechanical compression right on that spot right there I showed you with the X. And again, that's the brainstem, that's the medulla, that's where all of the vital life centers are. That will not make you very well in the least. And there's a hypothesis out there that one of the reasons why a Chiari malformation is going to occur in the first place is that it's essentially an airbag of sorts. And in fact, there's literature out there that shows that when people have a known basilar invagination, this issue that we have right there, if they don't have a Chiari malformation, symptomatically they are so terribly much worse. So this is not to make light of any of the issues that can happen with a Chiari malformation, but let's think about this for a sec. If your medulla is the area that's responsible for your heart, your breathing, your blood flow, that all of your physiology in your body, in other words, keeps you alive, and the cerebellum is the part that controls your muscles and your movements and your sense of balance, if you have to compromise one of them, and this is one of those Sophie's Choice kind of things, but you have to sacrifice one of them, which one is your brain going to select? It's going to say, we need to keep you alive at all costs, even if it means we have to sacrifice the other part right here. In other words, it seems that the descent of the cerebellum at times can be one of the body's innate protective mechanisms, as bad as it is, against something that's actually worse from a neurological perspective. So we can measure that. And again, this is a risk factor here. You can't change your bones, you can't change your genes, but you need to be aware of this, because you need to make sure that the joints are all stable in the upper part of your neck in particular. And I'm going to hit on that in just a second, because that seems to be what one of the major risk factors is about why these things become symptomatic in the first place. So I'll get rid of a couple of my little X's, and I do want to show you one other thing right here. There's also what's known as a clivo-axial angle. This refers to an angle that's formed between the base of the skull here and then the orientation of the C2 vertebra like this. So if I kind of draw that out a little bit bigger, it makes a acute angle. Well, excuse me, that's an obtuse angle like that, but a deflection of sorts like this. Now, normally we like to see that angle is somewhere between about 150, 165 degrees if we're measuring that on an MRI or any other kind of advanced imaging. The kicker is that if that angle is either too sharp or if it's too steep, these are both risk factors that promote upward translation of that C2 vertebra. And when that happens, the air blag is going to have to deploy in those circumstances. Now, what can make that worse? Physical injuries, whiplash injuries in particular. A whiplash is anything that is going to involve a snapping action of your head like this. It doesn't have to be caused by a car accident. So what would be a few common examples? Well, headbanging at a rock concert. Bungee jumping if you get the spring and your head's in just the wrong position. You take a nasty slip, a trip, a fall. You smack your head hard playing sports. You get tackled one way and then you hit the ground and your head snaps back the other way. Now, in and of itself, these injuries do not cause Chiari malformations because we know that the ligaments of this area are exceptionally strong. They are designed to prevent this downward pulling of the brain, because like we said, brain going down into the spinal canal area, this is not going to be a good thing. But imagine what would happen if over the course of your life, you've already got these risk factors, but then you have a series of accumulative injuries that break down all of those normal protective mechanisms. If that happens, there's no other option. And what can happen is then the thing starts to default down like this. And this is why, as we said and we know from the research, Chiari malformations, they seem to be 3 to 4 times more prevalent in people who have had complex neck injuries of some kind. and hitting on it particular, it seems to be that instability, that is ligament laxity of the C1 and the C2 joint space. So that's the C2 here, and that's the C1 right here. This is the joint that allows you to pivot your head side to side like this. If those ligaments are compromised, that seems to be one of the major factors that can cause that C2 to go up, and as a consequence, the airbags start to deploy and we start to develop a symptomatic Chiari malformation. Now, on that note, I should add something else here, and that is just because a person may have a Chiari malformation, it doesn't mean that they're necessarily symptomatic. In fact, if you were to take MRIs of 1,000 people, you'd probably see something like this in somewhere about 5 to 10 of the population, and this is 5 to 10% of the population with no symptoms whatsoever. This is the adaptive power and the innate healing mechanisms of the body at play. Your body's designed to win. So it's going to do whatever it takes in order to compensate for these different stresses. But like we said, if you've got this, plus this, plus this, there comes a point where your brain, essentially your body says, dude, we can't take this anymore. And that's when we start to experience these different kinds of weird neurological issues. So just because we may be describing this, I also want to clarify that this is never in terms of absolutes. Just because you may have these different things going on doesn't mean that you need surgery, that you're going to have symptoms, or that your life is ruined. And it also doesn't mean that things cannot go back to where you are feeling an awful lot better. Now, I'm going to come back to this particular picture again right here, where we talked about the sharpness of this angle right there. We also know from the research that if that angle is particularly sharp, about 130, 135 degrees, remember it should be 150 to 165. If it is much, much sharper than it should be, even if you have a laminectomy, it's not going to work. Sorry, we can't change the bone structure, but it means that surgery would not be an option that's actually going to help. Instead, you have to focus and do whatever it takes to help to stabilize the joints of your upper neck so that it can give your brain at least a little bit more wiggle room. And this is one of the good bits of news that I do have to share here, is that if you can make functional improvements in the functional space, even by as small as 1 to 2 millimeters, that oftentimes is enough where your brain says, thank you. This isn't perfect, but we can work with this, and where we start to have improvements. So on that note then, let's jump ahead to a few of the different treatments that are available when a person has a known Chiari malformation, and then I'll cycle it back to what does this person think about actually having work done on their neck. Okay, first up, I want to hit on surgery. Surgery is sometimes going to be medically necessary, depending on the severity of what is actually going on. But as I also had showed you, there's going to be times where surgery in and of itself, it's not going to solve all of the problems, because even if you do take some of that bone away, it's going to compromise the muscle and ligament strength of that area that's necessary to stabilize it in the first place. So you also need to make sure that you are doing the kinds of things that promote stability in that particular area. So there's a time and a place for surgery, but as a general rule, you want that to be your last option. And even if you have had surgery, you still need to make sure that you're doing the things that are going to promote stability in that particular area as well. One of the most common ones that's out there, if you've done, again, any amount of Google on this topic, is an emerging field of medical science, which is known as Prolotherapy. In a nutshell, it is injections using a slightly noxious substance, but nothing, severe or anything like that, into the muscles, into the ligaments of this area that promotes and allows them to tighten back up. Now, I think prolotherapy is a really good thing for a lot of people, but I'm going to have to disagree with some of the literature that's out there, because what these guys are talking about is persistent craniocervical instability. True instability of ligaments occurs when a joint is moving 50% more than it should be. And in particular, again, what are we talking about? We're talking about issues between the C1 and the C2 vertebra. One of the things that's unique about C1 and C2 is that it is the only joint in your entire spine that does what's called axial rotation, pivoting action. All of the rest of the joints, they either have locking discs or they have locking articulations which limit that particular type of motion. What my point here is that if you have a problem with any joint in your spine, particularly in your neck, because these are the spots, the major firing line, either the joints just above C1, C2, so the one between the skull and the atlas vertebra, or if you're talking about issues between C2 and C3, that C1 and C2 is going to have to overcompensate. And as a result, it's going to become what's called hypermobile. Now, the C1, C2 instability can still be an issue, but let's think about this, is if you've had some kind of a mechanical injury that affects either the joints above or the joints below, and the C1, C2 is simply a compensation for that, even if you have the injections, things are just going to get loose again because the primary issue is still not resolved. Remember what I said in the beginning of this video. When we're talking about a Chiari malformation and cervical stability, we are talking about a physical condition. Therefore, we need a physical resolution. And again, if the ligaments are just straight up torn, yeah, you're going to need everything that you can do to make sure that those ligaments can heal up and provide as much stability as possible. However, if those ligaments are actually part of your body's compensation mechanism, you still need to figure out what is actually causing that joint to become excessively mobile in the first place. And in my own experience, there are two major factors that are involved. The first one is your TMJ alignment, the alignment of your jaw and how your teeth come together. The center of axis of your TMJ is actually the center of axis. Axis is an AKA for that C2 vertebra. In other words, if the alignment of your jaw is wrong, for whatever the reason, maybe you had a direct jaw injury when you were young, maybe you have a substantial overbite, maybe you had braces or some kind of a dental procedure that shifted the alignment of your jaw, but it's not sitting in a neurologically healthy position. Your teeth might be straight, but your brain says, whoa, we've got these other risk factors at play here. We actually don't want the jaw in that position. It starts to create tension right through here. And what it will also then do is it's going to try to disperse some of that tension into the neck. And if it is incorporating too much torsion through that area over a long period of time, this is like stretching a rubber band. It's a process which is known as hysteresis. Those ligaments then start to stretch due to that constant stress. And even if you inject those ligaments to make them tighter, that's a good thing. But if the thing that was causing that excessive mobility in the first place is still there, those ligaments are just going to loosen back up. So it's not, don't misunderstand me here. My purpose in this explanation is not to bag on the prolotherapy, the functional medicine that's involved with this, because this is super important. But what I simply want to illustrate here for you is that it's not a one-size-fits-all. Neither is addressing the TMJ, and neither is going to be addressing the neck, as I'm going to describe next. What I want to impress on you is that unfortunately, there's a lot of moving pieces here. Some things we can address, some things we can't, but there's not one magic bullet solution. There's a few bits and pieces that are involved so that you can get the best kind of outcome here. And anybody who says, oh yeah, I've got the one magic cure that's going to fix all of that, that's simply put not true. So TMJ, major factor. The other one is the function, the mobility of what's going on between the base of your skull and the top vertebra in your neck. So that atlas and also the C2. These are the ones that promote mobility and support the weight of your head like this. But of interesting note, this is the only part of your spine that does not have a disc that locks it into place. As a consequence, when we have whiplash injuries, this area being the end of the whip, one of the weakest areas in the spine, is one of the areas that's damaged first. And unfortunately, it's also one of the areas that is least recognized as a major factor. In fact, many people where they have a brain MRI, they cut it off just above the level of C1. Because why? They wanted to see the brain. They don't need to see the neck. And when people have a neck MRI, they have a tendency to take it all the way up to the level of C2, but then they clip this critical area to see what's actually going on in the first place. So if that joint has been imaged and not broken, not dislocated, but where it becomes locked in an abnormal position, it changes the orientation of the head like this, and you then begin to lose the stability of that particular area. We also know from the research, what does it take to actually impact that particular area? A whiplash injury, no more than about 12 miles an hour. And that's if your head is in a forward position like this. If you have your head turned, or if you get hit from the side, it's even more likely going to be injured. In other words, it may take even less. It may take only 5 miles an hour to injure that. And we have, again, all kinds of physical injuries over the course of our life. We slip, we trip, we fall, we have bumps and bruises, we think nothing of it. But it's the accumulation of this physical damage over a period of time. That is what can lead to these kinds of issues, especially if you have those other risk factors. Like we said, there comes a point where your brain and your body say, dude, we can't do this anymore. And that's when the system starts to fail. And what we need to do then is we need to make sure that what we are doing is promoting stability and normal function back through those key areas that are involved. We need to make sure that your upper neck is actually moving the way that it's supposed to. Not too little in one spot, not too much in another, but balanced. We need to make sure that the jaw is moving the way that it is supposed to, and that every time you bring your teeth together, you're not just causing things to stress and strain into that wrong position again. And then, if there is significant ligament damage, then yeah, you may need additional injections, which are going to facilitate, help that to heal. And depending on the symptoms you have going on, you may also need to help to do a few things that's going to help your brain to compensate for this. You may need to work with a vestibular physiotherapist, a myofunctional therapist, a myofascial therapist. There's a lot of different moving pieces that are involved here. And again, there's not one magic cure. But what I want to illustrate here is that ultimately anything that you do that is promoting stability through the upper part of your neck, this is going to be a good thing. And one of the key factors for any person who has a Chiari malformation if they actually want to experience functional improvements. So as we're getting closer to wrap here, and this is a slightly longer video, but I hope one that's been worth your while and your effort here. So this person's had the surgery, they still have some issues, and they've been seeing what's called a NUCA Craniocervical Chiropractor. This is a different field of chiropractic. There is no stretching, twisting, manipulation, cracking, nothing like that. There is for most people, if you're not familiar, there is a special division of general chiropractic care. It's what's known as a craniocervical or upper cervical specialty. This is where we take advanced diagnostic images so that we can see exactly where are those vertebrae misaligned, where would they not be moving properly. And as a result, we then say, okay, you use the lightest amount of force necessary to help promote stability in that area. And these methods, again, they are done without twisting, without stretching, and without manipulating the neck. So especially if this person's had a laminectomy, the last thing that you would ever want would be somebody pushing on the back of your neck. Why? Because there's no bone there to protect that area in the first place. So this, again, is going to be our atlas vertebra. This part of the bone don't exist no more. And we don't have attachments for some of the normal muscles that provide stability. However, if you are being safe, if you are being gentle, and if you are being precise, you can still use this part of the vertebra as a lever to help release tension in that area. And as much as I would like to say, oh yeah, here you do this magical little adjustment and it stabilizes forever and ever, amen, and you're going to feel absolutely wonderful. Again, if you've had a laminectomy, you've lost some of the normal strength and stability. So, in fact, what I would argue is that these kinds of procedures are actually not a contraindication, but these are important for promoting stability in that area. But what you don't want to do is you don't want to have anybody just willy-nilly be twisting, cracking your head around, because a lot of times those kinds of procedures, they can promote more excessive mobility in that area of the neck. In other words, it needs to be a targeted solution so that it's addressing the issues of what you want. And as I said, there are a number of different craniocervical or upper cervical techniques. In no particular order, we've got NUCA, we've got Atlas orthogonal, we've got what's called an HIO, a knee chest, we've got what's known as orthospinology, and we also have what's known as a Blair procedure. That's the particular kind of mechanism, the particular kind of work that I do in my clinic. And what I would say, simply put, is that would I personally have no issue seeing any person, even they're using a slightly different methodology, we're all working to achieve the same kind of thing. Precision, stability in the most precise, the gentlest, the safest manner that we possibly can to help promote normal health, normal function for people with these different kinds of neuromuscular kinds of conditions. So my thoughts are that yes, this is an appropriate kind of procedure. Now, always consult with the specialist first. And if you were to ask a medical specialist, if you say chiropractor, I'll just give you a forewarning, they're going to think of twisting and stretching the neck. It's not the same by any stretch of the imagination. There's no drugs, no surgery, and I repeat, no stretching, no twisting, no rotation of this area. It's designed to promote stability. So this is going to be one of those key factors that, in my opinion, can really help out. But get the individualized assessment first. Get the right kinds of images and also have a chat with your individual specialist as well. Because for some people, yeah, that might be the only thing that they actually need. But as I explained in this video, if you've also got some of those bony risk factors, if you've got the TMJ issue, if you have other factors going on, it's not going to be a magic bullet, a one-size-fits-all cure for any of these different kinds of things. But it is simply put one piece and one essential piece of solving the puzzle so that you can get the best possible outcome there so that you can actually get back to enjoying life at the highest possible level that you can. All right, I haven't done one of those long videos there in a while, so if you've stuck with me all the way through the end, first and foremost, thank you for that. And please do post any comments that you would have down in the bottom. Like and subscribe to the channel. Share this video with friends and family, anybody who you think would benefit from having a bit more of an explanation about what's going on. Because a lot of times people with these kinds of conditions, they've been to doc, specialist to specialist, but nobody's really explained that to them. And I hope that this video would provide not just a little bit more clarity about what the nature of the problem is, but most importantly, these are the options that are available to you to solving that puzzle so that you can get back to enjoying life the way you actually want. So please do like and subscribe, share this video with friends and family. If you want some more information, please do go to my clinic website, clearchirospokane.com. We've got links to videos, blog articles on a number of conditions all related to upper neck health. And if you want to find a specialist near you, there's a relatively new directory. It's what's called UCC Near Me. It's a list of other craniocervical specialists who do the same kind of work here, even if you are not in the local area here. I'd be happy to help direct you in any capacity that we can. But thank you guys again per always. This is Dr. Jeffrey Hanna, Clear Chiropractic. Get well, live well, stay well.